Hey, well, welcome everyone. I'm Kim Schreiner. I'm the founder and president of the Phil Simon Clinic Tanzania Project, and I'm also an infectious disease and HIV specialist. And tonight's speaker series is going to be a review of the findings from the Conference on Retroviruses and Opportunistic Infections in Denver, Colorado. All right. Can everybody see it? Somebody give me a thumbs up if you can see the big blue bear. Okay, very good. All right, so let me tell you a little bit about this conference. This is a conference on retroviruses and opportunistic infections, and this conference was started in 1993. It's a very interesting conference as opposed to the International AIDS Conference or some of the other scientific conferences in that this is one, invitation only, and two, it's a sort of merging of clinical professionals, research virologists, epidemiologists, public health folks. And so it's a very multidisciplinary group of individuals that are doing high-level research and thoughtfulness about HIV. This one was held in Denver, Colorado. And you can see the big blue bear at the conference center here. And so I'm going to kind of give you a brief dip into some of the findings. It's a vast amount of material. It's a very, very good conference with very interesting opportunities to discuss the complexities of HIV, but this one in particular had some very important findings. So, okay, let's go next. So it's hard to believe that it's been 45 years since HIV was first noticed in 1981. And I think had we known what a significant pathogen this was going to be and how difficult it was going to be to control it and to find treatment, how many years it would take to find even the most minimal type of treatment, and then actually begin to have some success in treatment, it probably would have been pretty depressing. So I think that that's what's really remarkable and makes it even more significant, the findings and the places that we are now. But it didn't come easy. And I think that the many millions of individuals who have perished from HIV/AIDS, this is their legacy, that it was their honesty, their activism, their voice that drove the scientific community and the political community to really work very, very hard at trying to get this epidemic under control. And we still have those challenges today. And so it's important that we don't let our guard down because this virus is a very, very challenging opponent and requires a great deal of careful thought. So 1981 was the very first case noticed in a patient at UCLA by Michael Gottlieb. It was published a few weeks later. And that was really the very beginning of what we were seeing with the emergence of HIV/AIDS in high-risk individuals. And again, it's been a very long journey. HIV probably was circulating fairly robustly in other countries, especially in sub-Saharan Africa for many years prior to 1981, but it was really kind of became much more of a significant pathogen at that point. This is kind of a timeline of all the major findings that have happened. And it's interesting, and I have a personal connection to this on many levels, obviously, friends and patients and colleagues and so forth. But also this has been sort of the arc of my career. When I first went into medical school in 1982, obviously the very first case had been discovered and reported, and it was really kind of beginning to circulate, but not much was known about it. And over the decades that I've been practicing, certainly it was very challenging at the beginning when I first opened my practice at Huntington Hospital and started the Phil Simon Clinic. Very little therapy for individuals. Everybody pretty much became sick and perished. And so it was really a very challenging time, but we persevered and really through, again, the persistence of science and activism, were able to kind of begin to understand how this virus worked and develop some very primitive therapies at the very beginning. So it's been a very slow process, but we are in a much better place now, obviously. And I think that that's why it's exciting to be able to share some of the findings today. As I mentioned, when I came to Huntington, I thought it was very important that we have an opportunity to speak to and to teach about HIV. And so we established the Phil Simon Clinic, which is still in existence. It's a clinic for underserved individuals with HIV. It has become the main area where we teach our residents about HIV/AIDS and other infectious diseases. It, of course, was always also the basis for launching our international project in Tanzania, the Phil Simon Clinic Tanzania project. So 1996 was an important year because that was the year that the protease inhibitors were released. And the protease inhibitors were the first really, truly effective therapy that seemed to suppress the virus where people actually got significantly better. Prior to 1996, most patients had to take many, many pills, some of which were very toxic and caused all kinds of side effects and really weren't able to control the virus very well. And I attended the conference, the International AIDS Conference, which was in Vancouver that year, and the title of that conference was Race to the Cure. Two things had happened in 1996. The first was the advent of protease inhibitors, which became a very effective treatment option. And the second was the utility of measuring viral loads. Viral load is a very sensitive assay using technology, PCR technology, where we can actually sample how much virus a person has. And so we were able to measure their response to these medications, and that has continued to be a very important part of managing patients and an important indicator of how the virus behaves, the ecosystem of HIV, if you will, in any individual. However, at that time we thought, well, we can suppress the virus really effectively with protease inhibitors, and if we calculate the number of years that it would take to eradicate the virus in that particular individual, we may cure it. Unfortunately, what we found is the minute that people come off antiretroviral therapy, their virus comes back. And that's been the challenge persisting to this moment. So it's really become a really bigger issue, and I think we were a little bit naive in 1996. That being said, we have made tremendous progress. We now have multiple treatment options, much fewer pill burdens. People don't have to take as many pills. I can remember many of my patients who were taking 45 pills a day, and occasionally some of them would say, I would do anything to be able to take one pill a day. And I am happy to report that we are now at that place where we are able to give one pill a day that's multi-drug therapy all in one pill. So we've really made enormous progress with that. We have multiple treatment modalities now. We can give medications orally. We can give it through a shot intramuscularly. And I'll talk about this as we move forward. We can also give it under the skin in subcutaneous fashion. We really are pushing for long-acting medications, medications that don't have to be given very often. And that's really a goal and was outlined at this meeting in particular. And we've also noticed and recognized the importance of using these drugs to prevent infection. Pre-exposure prophylaxis has become a very, very important part of controlling the HIV pandemic. We have a much better understanding of what the virus is doing and how it behaves and the immune's response to it. And I think all of these things are setting the stage for a realistic opportunity to think about cure. That being said, we have persistent challenges here on April 22nd, 2026. We still have 1.5 million individuals becoming HIV infected annually. That number may increase over since the last couple of years because of decreases in access to care through some of the cutbacks in international care for individuals with HIV. We have 40 million people in the world living with HIV currently. Every year, 650,000 individuals die from complications of HIV. Hundreds of thousands of individuals remain without access to antiretroviral therapy, and of course, then they can continue to transmit the virus or die from complications. We know that individuals who have spotty access to these medications can cause viral resistance. The virus becomes very resistant when it doesn't have constant suppression, and this can cause significant comorbidities, in other words, other kinds of illnesses. HIV/AIDS continues to influence other infectious diseases. Perhaps the most important one is tuberculosis, but also diseases like COVID. And so anything that where the immune system is suppressed, that other infectious diseases can kind of take advantage of that. And testing, treatment, and control of HIV remains dependent on access to care, global and national funding, and really the ongoing challenges of stigma reduction. Several years ago, the United Nations put together a program which they wanted to try to really set some pretty ambitious goals that by 2030, 95% of people living with HIV knew their status, 95% of people living with HIV had access to antiretroviral therapy, and 95% of people living with HIV had non-detectable viral loads. That was a very, and continues to be a very ambitious program. I don't think we're going to reach that goal at this point, but it's possible. Perhaps the last one is the most critical one. We've really seen in the last decade a turn in the HIV pandemic, especially in very high-risk countries in sub-Saharan Africa, because individuals who are fully treated and are completely suppressed are no longer infectious. And that's how you control a pandemic. So really the role of antiretroviral therapy now is to prevent sickness and death from HIV-associated immune suppression, to prevent transmission. We always say that U equals U, undetectable equals uninfectious, and to provide both pre and post-exposure prophylaxis for individuals who have been exposed to the virus in the attempt at preventing them from acquiring it from a high-risk behavior. At this point, we have about over 50 FDA-approved individual and combination drugs available in the United States. That is not true in many other countries. With the advent of what we call fixed-dose medications, in other words, multiple medications in one pill, this really significantly reduces the pill burden for patients on antiretroviral therapy. And once-daily therapy is really becoming sort of the standard. It's widespread. And it is even available in underserved countries. We want to try to tweak that a little bit more by having simpler regimens that have less toxicity and perhaps increasing the use of long-acting regimens where you come in and get a shot maybe once every 2 months. That's Cabenuva. We have that drug now. Or even once every 6 months. That's lenacapavir, which I'll talk about in just a little bit. The virology and biology of HIV is very complicated. It's very interesting, but it is very complicated. Basically, HIV uses the human T cell as a factory for itself. It's a very wily little virus. Remember, it's an RNA virus. Its genetic material is RNA. Our genetic material is DNA. So in order for it to produce more RNA virus, it has to mimic a DNA copy, and that's what it does. It uses the certain cells that are certain receptors that are expressed on these T cells to attach. It then squirts its genetic material into the cytoplasm, the outside of the T cell, and through the enzyme that characterizes HIV retroviruses, it converts RNA to DNA through retroviral transcription. That material is then integrated, that's an important word here because that's an area where we can use medications, integrated into the host's gene. Then 3 things can happen. This process can kill the cell, so you lose a T cell. It can sit there for ages and ages and ages and do nothing, or it can become a factory for other virus. And this happens in huge amounts. HIV has the capability of producing 10 billion new particles every day. And so it's a very challenging situation, but understanding how the virus interacts with our immune system and where it's interacting and how it does it through the various enzymes has been the key to developing different medications. And I will talk about this a little bit as we go on. But it is quite complicated, and I don't expect everybody to get it after this slide. So these are the current mechanisms that we have for antiretrovirals. And again, these are all enzymes that the virus uses to make itself. We have enzymes that allow it to change its RNA to DNA. We have enzymes that prevent the post-integration development of an infective capsule. We have the ability to prevent the virus from fusing to the T cell at the very beginning. We have the ability to prevent the virus from integrating its genetic material into our own genes. We can go out and grab virus and sort of make it less able to attach to cells through monoclonal antibodies. And then the newest and most interesting one is our capsid inhibitors. And I'm going to talk a little bit about that because that was a big feature at this meeting. So we have all these different mechanisms for attacking the virus. In spite of this, we don't have a cure. We don't know how to get that just yet, but we are beginning to understand why we don't have a cure. And so I'll talk about that as we move forward. Again, this is just another diagram of showing where all these different medications can interfere with the reproduction of more virus. And it does it, of course, this is done on millions and millions of viral particles and throughout the cells of the body. This is where all of the virologists are spending their time looking for new ways of attacking the virus. It's the best if you can attack the virus before it becomes integrated into the host's genetic material. That's called pre-transcription or pre-transcriptional interference, because then the host doesn't serve as a reservoir. Remember that word, that's a very important one for cure. Doesn't serve as a reservoir for more virus. That being said, many of our medications affect the replication of HIV post-transcription, after it's already integrated into the host DNA. And it's still effective, but you have to stay on medications, and these cells can remain quiescent. They can remain kind of in hiding and become part of the reservoir, which is so important in understanding how we could achieve cure. Every infectious disease now seems to have a monoclonal antibody, and ibalizumab, one of my goals is to always know how to pronounce the monoclonal antibody, is the one for HIV, and that acts in a post-attachment inhibitor area. But this is something to remember because these medications are going to be important in achieving cure, and I will come back to that as we get there. I mentioned lenacapavir and the capsid. HIV this is an electron microscope picture of HIV. It's this kind of envelope, this little circle. And remember, this is a ball. This is not a 3D look at it. And inside it has this conical thing, which is called the capsid. And the capsid, inside the capsid is the genetic material for the virus. It's kind of this protective, weird conical thing. Sort of looks like something you might think about in the Project Hail Mary book with the astrophages. But anyway, it's a very interesting thing, and we hadn't really understood exactly what it did. Over the years, it's become much more important in terms of understanding how it behaves and what it does. And there's a lot of complexity to it that I won't go into here, but the capsid inhibitor, the capsid itself, is an area where we can attack the virus, and that's the advent of this new family of medications called capsid inhibitors. And so it's something very important to think about. So capsids have these kind of weird shape like this, and that it increases the exposure, the surface exposure of the virus. And then there's these little clumps where the virus sort of interacts with the cell. And what capsid inhibitors do is they prevent the formation of the capsid. And when they do that, it basically doesn't allow HIV to infect the cell. And so this is a new family of pharmaceuticals. Gilead was the first to produce this. Viv, another pharmaceutical company, and GlaxoSmithKline are both coming up with capsids. But it's becoming a very effective method of interfering not only with the actual virus, but also preventing the establishment of the reservoir. Interestingly enough, this technology also may be very helpful in dealing with other kinds of viruses that have capsids. Not all viruses have capsids, but there are some, and perhaps the most important group are herpes viruses. So things like Epstein-Barr virus and cytomegalovirus and so forth are viruses that we don't have very good therapy for. This is an area where we may be able to really make some differences. This is a kind of cool picture of a capsid inside this little HIV viral particle. So what is the patient experience? Well, taking the pills is great. It suppresses your virus. We know now that patients that are fully suppressed are not infectious. That's terrific. They usually feel very good. They are not susceptible to opportunistic infections, and really they live quite a long time, if not a normal lifespan. So suppressing the virus fully with medications has made an enormous change in life experiences and health of patients with HIV. But it does require you to take the medication. And so it is compliance dependent. You have to be compliant to take your medications. If you come off your medications, the virus comes back. You have to be able to have access to the medication. And that's a really important factor here. And that speaks to the fact that there's so many issues that are surrounding access to any kind of medications, but especially HIV medications, that can really influence where the pandemic goes. We have programs such as the AIDS Drug Assistance Program here in the United States that allows patients of low income to have access to these very, very expensive drugs, to go on therapy, to become non-detectable, to not spread the disease, to become healthy, perhaps go back to work, get their own health insurance, and it's really a very productive thing. George Bush started the President's Economic Program for AIDS Relief in Africa, a highly successful program that has been part of USAID. It has taken a serious hit with the recent cuts in international care for patients with HIV. But there are vestiges of PEPFAR still kind of struggling along that are trying to provide therapy for individuals. Very, very important project, a very important and impactful one under the Bush administration. That being said, there are some noises about limiting treatment opportunities here in the United States. Again, with ADAP, has long been a program that's been highly successful, but I think there's been some interest in trying to remove it from federal support. So we'll see where that goes. But the problem is that when you take away the access to therapy, then the pandemic spreads again. And HIV doesn't care who you are. It doesn't care how much money you have. It doesn't care what color your skin is. It doesn't care what your sexual orientation is. It really doesn't care about anything except finding a host. And the only risk factor for HIV is to be a Homo sapien. So when we deprive individuals who are infected from treatments that are can successfully suppress their virus and make them healthier, we increase the risk for everyone. And that's why it's so critically important with this pathogen in particular to maintain robust support and access to medications. The other area that we're really looking at and feeling very confident about now is to improve compliance. You can develop long-acting medications that can be given in novel ways. This provides more consistent viral suppression. The virus isn't popping up every now and then and becoming resistant. It can be very discreet, so it just diminishes stigma. And it plays a role in both therapy and in prophylaxis. So we're looking at therapies that are long-acting. In other words, you get it once every 2 months or once every 6 months or once a year. That's sort of the goal. Maybe given in alternative ways. It doesn't have to be a pill. It could be a shot. It could even be sort of a drug-eluting little implant that goes in, much like we use in birth control. And so those are all areas that are really active right now in antiretroviral therapy and can potentially translate into other kinds of medications and medication modalities. It is critically important that all of the research that we're doing here in the United States and have done on antiretroviral therapy is also shared and done in countries that are underserved and are very high risk for HIV. And that has been a really big push on the part of the International AIDS Society, PEPFAR, USAID, and the Infectious Disease Society of America to make sure that a lot of these novel medications are studied and the research is done in countries that are very high risk. So these are 3 studies, Latitude, CARES, and Impact, that have been done largely in sub-Saharan Africa with remarkable results with cabotegravir rilpivirine, which is Cabenuva, that's a shot, a long-acting shot. You see it advertised sometimes on television. And then a study that was done with lenacapavir. And there's all kinds of challenges in underserved countries, both with access, transportation, cold chain storage of medications, but these have been very, very successful with very robust data. All of these studies have shown that most of the long-acting medications that we are using now very frequently in the United States can be used successfully in underserved countries and in resource-poor countries, and that they are non-inferior. In other words, they're just as good as people who are very compliant with oral therapy. So those are really important findings. And again, as we move forward and start deploying different types of medications given in different types of ways, we want to make sure that the most high-risk areas in the world have access to this. So other potential new agents that I won't talk about too much until we get to cure are broadly neutralizing antibodies. Remember, I mentioned the monoclonal antibodies. lotibibart is one that's being produced by Viv. That's an intravenous medication. There's early trials with giving cabotegravir, which is an integrase inhibitor, subcutaneous again, and very infrequently. And then looking at long intervals, maybe 4 to 6 months between having to give a medication. There's also trials looking at giving twice yearly intravenous therapy. So that would really be a game changer for many people that have access to that kind of possibility. But that isn't the final story here, and we've got to keep pressing on. This conference talked a lot about other medications, newer medications that some of them are still being studied. Islatravir is a once weekly oral therapy. There's a phase 2 study being done with islatravir and lenacapavir, the capsid inhibitor, looking at every 6 months. And that's really been a huge step forward. We can use these drugs in pre-exposure prophylaxis. Doravirine is also a medication that hasn't been released yet, but is very close to being released and will be another sort of arrow in our quiver in our battle against HIV, and it's a long-acting medication. I mentioned GlaxoSmithKline as well as Viv are developing a new capsid inhibitor. This is the sort of the real exciting area of HIV antiretroviral therapy because it has to be given, it doesn't require being given more than twice a year with excellent virologic control. It can be given to people who have highly resistant virus, and it's a very, very effective therapy, very well tolerated. It's a subcutaneous injection. The only problem is the Gilead capsid one is that it can interfere with some other kinds of medications and cause drug-drug interactions. So new strategies for oral therapy would be giving a once weekly therapy, perhaps using lenacapavir subcutaneously and islatravir once a week, or combining it with an integrase inhibitor combined with, this is a new one, with lenacapavir and islatravir, and then maybe using broadly neutralizing antibodies to suppress effectively in people who have had some viral breakthrough. But these are kind of clunky medications, and they're quite expensive and usually have to be given intravenously. So this is lenacapavir, Gilead's drug, Sunlenca. Again, very, very impressive performance and has very good suppression. I've had a couple patients that have highly resistant virus, have had that for many, many years, and it was this drug that finally got them to non-detectable and they're doing excellent, and that's just fantastic. It is given subcutaneously once every 6 months, really minimal side effects. It is exorbitantly expensive. And that's one of the big problems in terms of these long-acting and ultra-long-acting formulations. But the way things have gone in the past is that eventually these drugs do become less expensive and more accessible if we're creative about how we deploy them. So I want to briefly talk about how to prevent HIV and also how to prevent chlamydia and syphilis. And so we might mention the fact that individuals who are who have HIV and are fully suppressed are no longer infectious. But we also know that pre-exposure prophylaxis works pretty well for individuals that are at high risk. And the mainstay for pre-exposure prophylaxis has been a pill called tenofovir disoproxyl fumarate, or Truvada. That particular type of tenofovir is a little bit more toxic to the kidneys, and so we have tenofovir alafenamide, which is a little bit less toxic. Those are both drugs we use a lot in treatment, but they've proven quite effective in pre-exposure prophylaxis. Some individuals take 1 pill a day all the time, every day, if they don't sort of know when they're going to be sexually active. Perhaps they go on vacation and they take it for the 2 weeks that they're on vacation. In individuals who can sort of predict when they're going to be sexually active, they can do the 2-1-1, where they take 2 tabs 2 to 24 hours prior to sexual activity, 1 tablet 24 hours after, and then 1 tablet again 48 hours after. These have been quite effective therapies, but they do require compliance with the medications. Happily, we have not seen an emergence of resistance. That was one concern that we had when we first started talking about PrEP, but that really hasn't happened too much. So we're pretty excited that this is still a very effective way of preventing transmission. I'm not going to go into this too much, but this is just emerging strategies for PrEP that it would include, again, other kinds of molecules, some of these longer acting medications like lenacapavir, islatravir, and the possibility of using nanoparticles and supramolecular polymers, which don't ask me to explain that one. But all of these are really studies that are being looked at. And really, the thing to remember with HIV antiretrovirals, the development of antiretroviral therapy, is that it spills over into many other diseases. And the most recent example of that was COVID. Of course, Paxlovid is a protease inhibitor, and that drug was developed directly from our knowledge about protease inhibitors in HIV. So all of these innovative therapies, both for prophylaxis and for treatment, not only help people with HIV, but help people that have other diseases, and have been enormously important in understanding even opportunistic infections in individuals who are immunocompromised for other reasons. This was an amazing study that was done. Again, this was done in Uganda and South Africa for lenacapavir, Sunlenca, and it was called the Purpose 1 trial. And it took about 5,000 participants. Most of them were cisgender adolescent girls and young women, so very high risk for HIV. And they put them into a double-blind randomized controlled trial. One group received a subcutaneous injection of lenacapavir every 26 weeks, and the other group received access to oral tenofovir-containing regimens. So they both were given PrEP. But what happened is that in the results, there were 55 cases of HIV infection in those that had received the oral therapy, and no cases in the subcutaneous lenacapavir group. That's astounding data, and that the study was published quickly after it became available in the New England Journal. Subsequently, there have been a few cases of two cases of lenacapavir, two cases of HIV that was acquired in individuals that were on lenacapavir, but the circumstances around that were a little bit unclear, and they talked about this at the conference. But this is an interesting and a very, very important trial. What it tells us basically is that although oral PrEP is highly effective, it is dependent on compliance. You have to take the pills to prevent getting infection. And that can be hard for people. They forget, they don't have access to a steady dose of pills, they don't have access to clean water. There's all kinds of things that can really be significant barriers for this. If you come to a clinic and you get a subcutaneous injection and you're good for 6 months, that's going to give you pretty sturdy protection. And that was why there was a significant difference between these two groups. That also is a very interesting idea, because if you give an individual a medication that prevents infection, and you have to give it every 6 months, is that a, dare I say the word, vaccine? And we have long been hunting for a vaccine for HIV, and actually it might be in the form of an HIV medication rather than in some sort of antibody producing type medication. But that's still an interesting idea and a challenge, and we'll talk about that briefly at the end. So this was just the follow-up of the Purpose 1 study that I mentioned. 2 in the lenacapavir group did get HIV. There were no HIV capsid inhibitor mutations, however, so there seems to be a pretty high barrier to getting a capsid inhibitor mutation with lenacapavir. So I think the future of pre-exposure prophylaxis is going to be long-acting injectables and then intradermal implants or alternative delivery systems. But this is an area that's going to be, I think, really very important in preventing HIV infection. Jean Marazzo is the president of the Infectious Disease Society of America. She was the former CDC director under the Biden administration. Really incredible woman, great advocate for the underserved. And she did an interesting talk on doxypep, which is basically a pre-exposure prophylaxis for syphilis, chlamydia, and gonorrhea. Really, really significant STDs that often go hand in hand with HIV and often can be very silent. And of course, those of us that were following patients during the worst of COVID saw a huge increase in the issue in cases of syphilis in the general population in Los Angeles. So much for social distancing. But syphilis continues to be a real challenge. And so there's been an interest in doing the same kind of technique that we've done with HIV and providing therapy prior to unprotected sex. And this study was produced, the data that was from the doxypep study was presented by Dr. Marazzo, and very convincing that this is an interesting way of preventing 3 other very significant diseases without incurring too much resistance in these particular diseases. And I had to show the Foxy-Doxy study just because it would have the best picture. This is a trial of adolescent and young women who got a single dose of doxycycline after high-risk sex and see if they could and see if they can prevent syphilis, gonorrhea, and chlamydia. They're still recruiting patients for this study. I believe most of it's being done in the Northwest, but it's got a sexy name, and it's maybe really a very significant study. Okay, so let's talk about the four-letter word that we used to never mention in the world of HIV. Cure has been always on our minds, and when the protease inhibitors first came out, we thought maybe we had the capabilities of achieving that. In 1996, I mentioned. But that, of course, has not happened, and it's been a really big challenge with this particular pathogen. So the questions really are, can we do it? How do we do it? And should we do it? And those are always the kind of questions we have to ask ourselves when you're dealing with diseases that require a great deal of therapies that are very expensive, and how do we best provide the most care for the most people, and keep it so that it's also equitable for people that don't have access to these kind of medications. So I mentioned the conference in Vancouver for a race for the cure, and again we thought, well, we can calculate the viral half-life because we have this new test called the PCR, and we had these great drugs called protease inhibitors, and we were suppressing the virus. Problem is, the minute you come off the medications, the virus rebounds. Now this can take 2, 4, I even see 12 weeks, but everybody who comes off HIV medication who's HIV infected will have a rebound. So that's the evidence that you can't achieve cure just with super suppressive medications. So why should we pursue cure? Is it realistic? Can we achieve it? I think we can. Why should we pursue cure when we have such good single pill therapies? Well, sometimes you run out of pills, or you don't have access to pills, or the pills make you sick, and so your compliance may not be that good. How do we achieve this? It's probably going to require multiple methods. We have lots of unknowns about the human immune system and how it interacts with HIV. And of course, expense these are all factors that really will dictate how, when, and where we're able to achieve cure. Again, why should we go after cure when control is so good? Because too many people need treatment for too long. That's kind of the simple answer. It's not easy taking these medications all the time. And all the things that I've talked about, I think really show that it would probably be much more economical if we could get to the point where we could cure this disease rather than just constantly treating it. And I think that that's the goal for so many people. So to understand cure, we have a little vocabulary here. We have to use the word reservoir. This is where the virus hides, and we didn't really know very much about this, or even that the virus had a reservoir until the last 20 years or so. We need to talk about replication-competent viruses and clones. In other words, viruses that have the ability, once they wake up, that they can make more virus. And clones, that's an important factor because that would be a virus of all of the same making. And that's significant when we talk about how we would achieve cure. LRAs, or latency reversing agents, are very, very important properties and medications that we're looking at for what we call shock and kill. You basically tease the virus out of the cells where it's being hidden and kill it. So this is a whole family of drugs, that some of which we already have, that are pretty nasty medications, but they may be able to achieve what we're trying to do. Envelope and TAT proteins are proteins expressed by HIV. They are virulence factors. TAT controls the actual replication of HIV. Those are important to understand when you're talking about cure. I mentioned broadly neutralizing antibodies, these big antibodies that can go around and grab HIV that's kind of floating around in the cell or in the person's immune system. And then nanoparticles, which would be much more sophisticated little particles that can be used and perhaps deliver some of the more sophisticated immune things that we're talking about now. You probably know a little something about CRISPR, and we all know about mRNA, basically to send information to these latent infected cells and kill them. So all of these things are being looked at right now and were discussed in detail at this meetings, but all of them are in the various earliest stages of development. We have cured HIV already. We now have, I believe, 10 people that are cured of HIV because they all had an HIV-associated cancer and received a special bone marrow transplant that did not have the receptor that HIV uses to attach, the CCR5 receptor. the most recent one was one at City of Hope. I had the pleasure of attending this meeting with Dr. Jana Dichter, who's a fantastic HIV specialist at City of Hope, and it was her patient that received it. She also has, I think, 2 more patients now that may get to this place. But it's a very arduous journey for these folks. They undergo bone marrow transplants. They get very immunosuppressed and can have graft versus host disease. Timothy Brown was the very first patient. And so it's really challenging. And of course, they can get HIV again. That doesn't mean that they won't get it again. So it is an important part of their an idea to understand the strategy of cure, but it's not a very practical one. There are a few individuals who have never developed HIV. They were highly exposed. They might test positive, but they never go on to develop disease or express virus. And a couple of them are women. And it's not exactly sure what's going on here. They either had sort of a weak virus or they have an exceptional immune system, and that may be the latter. And we know that among primates, sooty mangabeys, which are a primate in Central Africa where there's a lot of HIV, they can get HIV, but they never develop AIDS. And so they've been looked at a lot in terms of what's going on with their immune system. But again, these are kind of difficult, challenging things and probably don't apply to most people, so we have to look for something else. This was a big breakthrough in 2022. Janet and Bob Silicano, who are the individuals that are sort of credited with really discovering what's happening in the reservoir of HIV. It was originally thought that the reservoir where HIV hides was comprised of long-lived, non-replicating resting memory T cells. But now we know that this is actually an active environment. It was the Silicanos that found this, that there's active replication, although it's very low level, going on in these special T cells that are harboring the virus. Why is that important? Because if there's replication, we can interrupt that. And if we can interrupt that, we can decrease the size of that reservoir, perhaps to the point where the person would never go on to develop AIDS, and they can come off HIV medications and not spread the disease to other people. But this was a hugely important breakthrough in terms of understanding what was going on with HIV. Some people like to think that cure is maybe too powerful a term and that remission might be better. And that is possible because we may never eradicate or sterilize any person from HIV itself. There always may be sort of these residual areas, but that by the time that person lives their entire life, 90 or 100 years old, they never would develop HIV and they never would have enough virus to transmit it. So that again, these are kind of functional cures, not necessarily true cures in that you're completely eradicating the pathogen. There's lots of challenges, obviously, that we've mentioned. Again, there's a lot of diversity among HIV itself. There's a lot of diversity in the human immune system. There's a lot of diversity in the presentation of individuals, gender, age, all those sort of things, what they've been on in the past in the way of antiretroviral therapy. So it's going to be a big lift, but I think it certainly is possible. And the strategies for cure are eradication. Perhaps we could develop an antiretroviral therapy that can penetrate these resting T lymphocytes and just get rid of it completely. That's a big challenge. Or reduce and control the reservoir. And that's really maybe the thing we're kind of focused on now. You want to try the shock and kill. You tease that virus out of the cell and get rid of it through these different kinds of agents. Or you teach the immune system to keep it under better control. So those are both techniques that we can use to achieve cure, where these individuals, again, could come off therapy and be able to never have any circulating HIV again, not have any of the consequences of HIV infection, and not be able to transmit it. Again, I mentioned these different techniques that are all, some of them are very, very technical and kind of complex, but they're all being looked at as potential cure mechanisms. Sharon Lewin is an Australian physician and sort of the lead person around the world looking at cure and understanding how the virus is behaving in people who are chronically infected, which is everybody who has HIV. And so she gave a lot of these talks about how do we tease the cells out. And basically, again, we have 2 types of cells. We have the cells that are productively infected, that are producing virus all the time. Those are ones we can control with antiretroviral therapy. And then we have this pool of cells that just sit there, but they contain totally viable virus. And that's the reservoir. And that's what we're after to try to achieve cure. Those reservoirs are in every person, every sex and gender. They can increase during stress. They are located in hard to reach areas like the brain. They may be comprised of different types of viruses. So these are all the challenges we're going to have in terms of trying to achieve cure in every person with HIV. And the idea is that we use these latency reversing agents to tease the virus to cough up its genetic material. And that induces it to express the RNA. And then we use a second drug, which basically kills it. And it also enhances or teaches the immune system to keep it in check. That's the idea. This is my own little cartoon of it. So what happens in arresting latent T lymphocyte that's harboring HIV, remember through reverse transcriptase, the enzyme that characterizes HIV, it's able to make a DNA copy of its RNA genetic material, and that sits in the host's genome. This is the host's DNA. Here's the HIV DNA. It just sits there. And then for some reason, the virus can activate the T cell and cause it to start making more proviral RNA, right? It goes from DNA to RNA. And then it uses the host lymphocyte actually to make these capsules that go around the virus, and then boop, off it goes. And this is done billions and billions and billions of particles all at the same time. So this is an activated T lymphocyte. This is arresting latent T lymphocyte. So by giving a patient latency reversing agents, we try to convert them from a latent T lymphocyte to an activated T lymphocyte, because these we can kill with other kinds of medications. And how do we do it? These are the broadly neutralizing antibody crowd. They go in and they attach to these viable virions and neutralize them. And if you just do it over and over and over again, you eventually exhaust the reservoir. And then you probably have achieved enough suppression of any HIV that the person, again, can live their entire life without being on antiretroviral therapy and not have recurrence of their disease. Those are pretty big ifs, but that's sort of the idea and the plan at this point. I'm not going to go into too much about broadly neutralizing antibodies, but they're sort of like little Pac-Men that go out and clear, virus that's free and can prevent it from binding to the T cells and then starting the process all over again. These are specific ones that are being looked at right now. It's kind of interesting. A couple patients, humans, have now been recruited for some trials, and they were talking about using these medications. And this is the one that would cause a killing of the latency reversing agent and then killing of the expressed virus. And during this lecture, after this lecture was presented, they presented some of the side effects, and these medications have a pretty significant side effect and a couple of very adverse reactions, including re-emergence of hepatitis B. And the presenter at that time, it wasn't this individual, was a little bit blasé about, well, it's a small adverse effect. And a couple of clinicians jumped up in the audience and said, that is not a small adverse effect. So that's why this is such a great conference, because it has this mix of individuals who are very much kind of the research lab bench folks who never see patients except when they're doing an experiment, and then the people who actually know these patients and take care of them on a day-to-day basis, people like me. So I think it's a really nice mix to kind of just, friendly reminder that these are people, and that adverse effect, though it may not be very much in your clinical chart, it's a big deal for the patient. So it's early days for HIV cure. We certainly have proof of concept. There have been some studies done in animals and humanized mice that look promising. A few studies with actual patients, it's very hard to do. There's a lot of possibility for unforeseen consequences. And we always have to be vigilant about potential drug toxicities or reactivation of other infections, especially hepatitis B. I'm not going to spend much time on HIV vaccines other than to say that some of these new therapies, as I mentioned early on with the lenacapavir capsid inhibitors, that actually may be a vaccine where we give it once or twice a year. We know that mRNA is a very exciting area for vaccine development. We, of course, have a lot of experience now around the world with mRNA vaccines because of COVID. Very, very safe vaccines and could be used for many other types of infectious diseases, including HIV. Also for many different kinds of cancers. So I think mRNA is going to be an area that we turn to for developing newer vaccines as we move along. And again, it might be challenged to develop a universal vaccine across all the different types of HIV. And that's why it's important to think about cure, because that's going to certainly diminish the amount of circulating virus around the world. What are the unknown challenges? What will gains in cure science do to the HIV pandemic? We don't really know. We need to access all infected cells. There could be areas where the virus still hides successfully. They need to be safe and available to everyone. And we have to be pretty humble about potential unforeseen or unexpected events. So these studies have to be meticulous and very, very well monitored. Finally, I wanted to talk a little bit about our current time. This was an interesting poster that was done by a Tanzanian, and it was accepted at CROI, which is a huge honor because it's a very competitive and prestigious meeting. And this little sign down here said that the individual who was the first author of this could not attend the conference because she was not able to come into the country because she couldn't get a visa. So it's a sad event. I have a great affinity for Tanzania, of course, as you all know. And you can see how political situations can really interfere with our progress in medicine and global health, and that we carry on and we do what we could. A lot of these folks that couldn't come, their colleagues who were in the United States or from Canada, presented their data, excellent data. And so the results still were there, but they themselves didn't have the privilege of being able to present at this conference. So just kind of a sobering situation, and we need to kind of pay attention to making sure that everybody has a voice. Finally, as I mentioned, the story of HIV and its treatments is really one of courage, innovation, determination, and advocacy on all parts of individuals involved in this. Certainly the patients themselves, the people with HIV, the caregivers on all levels, nurses, doctors, social workers, scientists, politicians, people with power, people with no power. It really is a human effort. And I think that we are coming very close to being able to conquer this infection. And the steps that we have taken and the steps that we are going to take in achieving that certainly spill over into many other types of infectious disease challenges. And I hope that in my lifetime, we will see that HIV is finally cured. So with that, I'm going to conclude 2 minutes early, and I'm happy to take some questions.